I'm Dr. Robert Kennedy, and we're going to talk today about some preventive measures for older people. This is sponsored by the Consortium of New York Geriatric Education Centers. And my reason for doing this is that I'm a consultant in geriatric medicine at my Meyers Medical Center and an adjunct associate professor of nursing at New York College of Nursing, and also incidentally a professor of clinical medicine at Downstate in Brooklyn. That is me. Now, this tells you a little bit about the module, where it was developed. It's developed by the Hartford Institute for Geriatric Nursing in cooperation with the Consortium for New York Geriatric Education Centers and New York University College of Nursing. The New York Consortium of Geriatric Education Centers is based primarily at Mount Sinai School of Medicine, but also at New York University and some other associated facilities. The program is funded by the Health Resources and Service Administration of the US Department of Health and Human Services. Now, here are the objectives of this module. You can read them for yourself. Basically, the purpose of this module is to outline some general rules for prevention in the elderly and identify the benefits of certain factors in the scope of prevention, particularly exercise, measures related to cancer screening, infections, osteoporosis, vision and hearing, heart disease, and finally cognitive changes and depression. But that will not be dealt with in too much detail, as other modules deal with that in their own time. We'll also identify issues related to medication reconciliation in the elderly, which again will be dealt with in another module in more detail. And we'll try to identify some preventive measures which are not recommended for the elderly. There is much concern about preventive measures which are not recommended as there are for those that are recommended. General rules of prevention in the elderly usually use guidelines, but they are applicable only for the large numbers of elderly people. Each individual must be considered as an individual when we're looking at guidelines, for some of them may not fit the guidelines, and we can't stretch the individual to fit the guidelines. A growing number of preventive services have been shown to be valid in the general elderly population, and that literature is increasing. It's also worthwhile noting that some of the preventive services that were previously thought to be of value in the elderly are no longer shown to be as valuable as was once thought. So there's a state of flux in terms of the preventive measures in the elderly. These are dynamic measures. They are not going to be fixed forever, and it's important that you keep up to date on this. In screening, for example, for cancer, the overall state of the health, the life expectancy of the older individual, and the functional status of the older person needs to be kept in focus. It's inappropriate to indulge in extensive workup if the older person is not able to cope with that workup, or if their life expectancy is limited. With the general increase in longevity, some screening procedures may be validated for younger persons, but may not apply to the very old. And this is part of the area which is still in a bit of flux, as I mentioned. Now, here are some general preventive measures. Most of you will know of these. They're basically common sense. Dietary evaluation. This is important in terms of our actual calorie intake. Older people, their appetite in their 80s and 90s tends to diminish. They can become extremely anxious, and so can their caregivers when they find that they're not eating as much as they used to. This is not to be unexpected. It's important also when you're dealing with diet to ensure that the older person takes a satisfactory amount of fluid every day. This should, at a minimum, be 3 pints of fluid a day, and sometimes more, especially in such situations where there is extremely warm weather. Dental care, again very important in older people. We now have many old people who still have a full set of teeth, which is unusual in terms of what used to be happening 20, 30, 40 years ago. So please pay attention to your teeth. Make sure that you keep regular dental checkups, and preventive dental measures pay dividends in terms of overall dental care, and dental care is essential for adequate dietary intake. Smoking. Smoking should be stopped at any age. You're never too old to stop smoking, and we do know that the sooner you stop smoking, the better the effect will be in your overall general health. Now, a question or two could arise about alcohol. We tend to evaluate alcohol intake in the elderly. It used to be thought that all alcohol in the intake was not a good thing, and that is now no longer the situation. We know, for example, that certain amounts of alcohol are beneficial in the elderly. We do know that up to 2 to 3 glasses, standard glasses of wine a day can be preventive in terms of a whole number of different conditions, particularly cardiac disease and other conditions. If there is excess alcohol, however, that is clearly not a good thing. And that is one of the reasons why we do suggest that all older people should have an alcohol evaluation. Many older people may take a considerable amount of alcohol and not reveal this. And there are certain ways they can do this by using what are called tonic wines, which are no more tonic wines than standard wine. Often these have a monastic association, and you'll often find that older people will take this, often claiming that they do not contain alcohol. This is not true. So alcohol, a reasonable small amount of alcohol, is relatively innocuous and beneficial. Too much, obviously, is injurious. Again, alcohol varies in the amount according to which sex you happen to be. We do know that men can cope with more alcohol than women, and that Caucasians can cope with more alcohol than Asians. So again, you've got to tailor the alcohol intake to the individual, sex-wise and ethnicity-wise. Falls are a major concern at any age, but particularly in the elderly, and increasingly so the older the person happens to be. Fall prevention, the identification of falls, and putting into play programs to help prevent falls is extremely important in later years. Falls basically will undermine the confidence of an older individual and lead to impaired activities of daily living. When that happens, the individual will start to show signs of deterioration, and this will be manifested in terms of not only activities of daily living, but overall morbidity and mortality. Retirement is not a time to stop exercising. It's a time to continue exercising and be involved in an appropriate exercise program. Fall evaluation should be assessed for all older people coming to see a doctor for the first time, just to assess how safe their gait is. There are standardized tests in this, the get up and go test and other tests, and you can find out more about them on the web by looking at www.consultgerirn.org, a very valuable reference for assessment instruments and how to deal with the results of the assessment. Environmental evaluation is also extremely important. A home safety checklist is best done in the individual's home. Questioning the person about it outside their home is not too valid. If there are major problems at home, many older people will conceal them. They're not going to admit their home is unsafe. Therefore, a person going into the home is the best way to get a safety check on what's going on. What are you going to look for? You're going to look for things like rugs which are loose, flexes and wires going all over the place, different levels of surface. You're going to look at the quality and quantity of the lighting. Is the lighting too dim? That's going to be a problem in terms of home accidents. You're going to consider pets. Are there major pets in the home? Quite a few older people come to grief by falling over them. So all of these kind of things are important. You've got to check on cooking. Is the older person safe to use the cooking situation, the stoves, and so on? Are they forgetful about leaving stoves on? A major problem with many older people when memory impairment starts to afflict them. So an environmental evaluation is extremely sensible for an older person, particularly a person who stays alone. And that evaluation will pay dividends in terms of preventing problems in the home. Now let's talk a little bit about exercise. I'm going to beat my drum about exercise. Basically, exercise is a good thing at any age, but particularly in the elderly. It's associated, we know from a lot of papers now, with a major increase in life expectancy. It also has a major effect in diminishing morbidity and mortality in terms of various different syndromes and diagnoses. It's advocated as a corrective for osteoporosis, which affects nearly all old people, women earlier than men, but men are still appropriately suffer from osteoporosis once they get into their late 70s, 80s and 90s. And the type of exercise is important also. There are those types of exercise which will deal with aerobic exercise, and that is basically very useful for general exercise and for cardiac training. There's also resistance training. That is basically resistance against weight. That is beneficial for joint flexibility and particularly for bone integrity. It's extremely helpful if there is persistent resistance training to minimize the effects of osteoporosis or indeed prevent it. Balance training. Balance is a big problem in later years. Many old people complain to their physicians, to their nurses, that they have difficulties with balance. A little thing can put them off balance. A perturbation, that is, a little push, may result in a fall. So balance training is important, and evaluation of balance is also very important in many older people. When you do find that, again, it's important that they're given a training program to help prevent it. There are certain programs which are valuable. For example, Tai Chi is extremely helpful in terms of improving balance training, and this has been documented in several papers in recent years. Now, we have a lot of problems in later years with joint problems, with arthritis, and if we pay attention to the pain and don't move our joints, they're going to stiffen up. Therefore, flexibility training for joints and ligaments is also extremely important. This, when a person has pain in a joint, that is not the indication to stop using that joint, it's the indication to continue using it as much as you can while you can tolerate the pain. So these are different types of exercise that we all should maintain in later years or talk to our older subjects and patients about. It's a good thing to notice that the older population is becoming much less sedentary than before. It used to be the situation that older people that retired all got their clock and their pension and retired home and became, in other words, a sort of couch potato. That is no longer, unfortunately, the case. Many older people now at retiral become involved in maintaining their mobility by exercise programs. These figures show that the number of people over 70 who are exercising in the overall US population has increased in the last 24, 25 years, and that is still happening. Many older people are active members of gyms. If you go to a gym in the morning, you usually find it's full of older people. Much to the annoyance of many of the younger people, the older people will be there and using the machines as well. These are a list of the diseases in which there is documented evidence that exercise is beneficial. Cardiovascular disease, that's important. Osteoporosis, that type of exercise is basically weight bearing. Falls, we've talked about. Obesity is not a reason to stop exercising, it's a reason to start exercising. Osteoarthritis, exercising in osteoarthritis will help to maintain joint flexibility in joints which are subject to arthritis. We know, for example, that dementia can be improved with exercise. There are several programs which use exercise as a means of aiding dementia patients, and we know that exercise can prevent dementia or retard the rate of development of dementia, and that's now a very important issue. Also, exercise tends to help to prevent depression. Obviously, a person who doesn't exercise is going to be more isolated than the person who does exercise. Other specific conditions such as diabetes is also benefits from exercise. So you can see that exercise is an extremely useful focus for older people, and they should always be encouraged to undertake exercise. Moderate physical activity is important. The older person is really not, in most instances, exercising to compete in as a triathlete or in a triathlon. What they should do is have gentle exercise, moderate physical activity, and this usually works out with greater compliance. If a person goes in for an extremely extensive exercise program, compliance tends to be much less than it would be with moderate physical activity. Now let's talk about preventative infections, and I'm sure all of you know most about this. Flu shots are standard every year for old people. It does help to prevent deaths. It does help to make pneumonia, if a person gets it, less extensive, less likely to last a long time. You should also, as an old person, have vaccination against pneumococcal pneumonia. Pneumococcal pneumonia is still the commonest type of pneumonia in the United States, and an older person is much more likely to get it than a younger person. We do have measures of preventing it by vaccination. This should occur at 65 or round about then, and if you've already been vaccinated, you should be revaccinated 7 or 10 years after the original vaccination. Herpes zoster Herpes zoster, which is shingles, that also can be helped to be prevented. Herpes zoster usually happens with what we call post-herpetic neuralgia. This is an extremely painful inflammation of nerves. It can happen over any part of the body, and it can be extremely debilitating. If this can be prevented, then it's very valuable. A herpes zoster vaccination is now available. It's not as cheap, for example, as flu shots, and it's a bit more complicated in getting hold of the vaccine and getting it administered. But if a person should seriously consider having herpes zoster vaccination in later years. Now, tetanus is an unusual condition, but it's a very lethal condition. It doesn't happen very often. But we do know that older people tend to be much more subject to it, even in small numbers, than those who are not old. So if you've never been vaccinated, it's advisable that you do have vaccination against it. If you have been vaccinated, it's appropriate to have a booster dose of tetanus vaccine every 10 years after the original vaccination. This particularly applies to people who are involved in agriculture, gardening, working in parks and so on, because tetanus spores tend to accumulate in earth, and that is usually the source of tetanus infection. We're going to talk a little bit about cancer screening, and this is a vexed area. It keeps changing, and this is one of the problems about some of the preventive issues with the older individual. Mammograms it's suggested, should occur every 2 years for women aged 65 and over who have a life expectancy of 5 years or more. But it's unclear at what age this should stop. And we get conflicting advice from different professional medical groups, depending on whether you're looking at it as a general practitioner or you're looking at it as a cancer specialist. So we don't know when to stop cancer screening in terms of older people. In most instances, it's suggested that in terms of mammograms, this should be discontinued in the early 80s or thereabouts. It's, however, for high-risk individuals where a person has already previously had a breast cancer, which has been successfully dealt with, or it's a strong family history of breast cancer, then screening should continue. Also, there are certain groups who've got the genetic predisposition to breast cancer, and again, they need to be screened much more frequently than those who do not have this problem. We used to teach that breast self-examination was a useful tool to determine whether there were any breast masses. We do know that breast self-examination is not really clinically efficacious. Certainly it should be done, but it is not really a preventive tool of value. Mammograms are. The other concern is what is going to happen if there is a positive mammogram. Again, the methods of dealing with breast cancers, again, keep changing. It's a question of read this spot to see what's happening. At the moment, what usually is suggested is that if it is a discrete lump in the breast, there should be lumpectomy with appropriate radiation on a long-term basis and a follow-up thereafter. This may, however, change. So in summary about breast screening, first of all, self-examination is not really clinically efficacious and does not take the place of mammograms. Mammograms should be done every 2 years for women aged 65 with a life expectancy of at least 5 years, but when we stop doing that is still not known. Those women who have a higher risk of breast cancer, i.e. familial or previous breast cancers, they should be screened more frequently and probably for longer. Now let's move on to cancer screening for the colon. And again, this is an area where there is a little bit of controversy. We've got to remember that at least 66% or more of cancers of the colon occur in those aged 65 or over. Also, don't expect that the person will present with finite symptoms. The symptoms are often very subtle. There may be anemia, there may sometimes be pain, but that's unusual. There may be altered bowel habit, or there may be no symptoms at all. It is now standard advice that people, once they reach the age of 65, should have a screening colonoscopy, and thereafter every 10 years until they are in their 80s. When to stop? Around about 80 or 85. Again, if there has been an abnormal finding at colonoscopy, that screening should continue for longer. What happens if you find a polyp, which is the initial lesion for a colon cancer? A polyp is usually benign unless it's been there for a long time. What happens at colonoscopy is basically the polyp should be removed. And a person who's had a polyp removed should have a colonoscopy every 3 years after that until there are no more polyps, and then they go on to a 10-year frequency. Frequency again can change in special circumstances. Certain families may have a strong history of colon cancer, and in those instances there should be much more intense screening for that type of cancer. The other thing to comment on about colon cancer is that stool guaiac testing, that is testing for blood in the stool, is not really a reliable means of testing for cancer of the colon. The gold standard is colonoscopy. Let's move on to screening of the prostate in men. Again, there's a lot of controversy here. And again, if you read the newspapers, every 6 months or so, a new article comes up suggesting a different attitude. First of all, we used to think that you would be able to detect a prostatic cancer on a rectal examination. But direct rectal examination is not really clinically efficacious. We do know that it can be helpful, but it is not the gold standard. We have a tool called prostatic specific antigen, PSA, which is a specific type of chemical which you get increased when there is prostate cancer. Elevated levels are associated with prostate cancer, but it can be associated with benign prostatic hypertrophy, which will happen in nearly all males. It will happen also in terms of when there's prostatitis, that is when there is an infection of the prostate. So there are other reasons for an increased PSA than prostatic cancer. The next thing to comment on PSA is it naturally increases with age. So the levels that are abnormal for younger people are not necessarily the levels that are abnormal for older individuals. The normal range I show you here is up to 4 nanograms per ml. But this does not exclude all positive men. Some men, unfortunately, can have positive cancers with PSA levels less than 4 nanograms. What should we do? Well, we can fractionate the PSA to get specific cancer-specific chemicals. That may help, but it's not normally done. How do we deal with the PSA when it's elevated? Again, what happens is we approach this with what's called watchful waiting. But it depends really on what has been found when the individual's PSA is elevated. Watchful waiting means regular observation of the patient with measurements of their PSA. If the PSA starts to go up very rapidly, then clearly there must be a cancer which is increasing in amount, and intervention should be required. However, many prostatic cancers can be managed by no involvement of surgery at all. I have had patients who have prostatic cancer who've had them for 20 years without any major effect. most men who have got prostatic cancer die from other conditions than cancer of the prostate. So it's a question of determining which approach you're going to take. The trajectory of the rate of PSA increase, as I mentioned, is important, and that is significant. There are certain groups that are more likely to develop prostatic cancer. Black males, for example, tend to develop prostatic cancer at an earlier age, and it often may be much more florid in black males. So you may want to check on the prostatic specific antigen at an earlier age in black men. The other thing to consider are the side effects of any interventions. Interventions for prostatic cancer really involve three distinct measures: interventional surgery, intervention radiation, or intervention hormone treatment, which involves basic castration. None of these treatments is without severe side effects. The important thing to remember is that the individual may be left incontinent and may be left impotent. And the man has got to understand this and be told about this so that he can make decisions according to how he feels should these side effects occur. These side effects occur in 10 to 15% of people who have interventions. Therefore, it is not inconsiderable. And if the alternative to intervention is watchful waiting, that might be the route to go. This is where it's important to use the advice of a skilled urological surgeon. And as I say, you're going to hear more about this because there's a lot of work trying to determine just exactly which individuals should have intervention and which should not. As to the three methods of intervention, all are equally successful, all have the same level of side effects, and it's a question of the skill of the operator and the wishes of the patient as to which way they want to go. I want to talk about cancer screening of the skin. Skin cancers are probably the commonest cancers in the elderly. They are not the big florid cancers like breast cancer, colon cancer, or prostatic cancer, but basically they're the commonest. And the three types that we're going to talk about here are squamous cancer, which occurs any place in the skin. It can occur in areas where you don't expect them. It can occur under hair areas, and this is important to note. Basal cell carcinoma, sometimes called the rodent ulcer, are little areas which occur on the skin, usually in the face, round about the nose and the eyes, and malignant melanoma, which occurs in areas where there is greater exposure to sun. Malignant melanoma is fortunately rarer than the other two, but unfortunately it's an extremely dangerous type of cancer, and it can spread very rapidly. If a person has got a mole, a pigmented mole, which shows any signs of increasing in size, that should be reviewed immediately. And importantly, it should be biopsied so that the individual can rest assured that they do not have that problem. We tend to manufacture these skin cancers by sitting in the sun. You find them much commoner in sunny areas. Australia, California, Florida. That's where you're going to get most of these type of cancers. It's due to actinic exposure of the sun on the skin. And again, without skin protection, this is going to increase. This is one of the difficulties when we have older people retiring to areas of high sun without using skin protection. I generally advise my patients to see a dermatologist at least once every year, every 2 years, once they reach the age of 65, 70, just to ensure that there's no problems related to developing skin cancers. Most of the skin cancers, the squamous cancers, the basal cell cancers, can be very easily dealt with if they've got early enough. Cervical cancer. This, again, is an area of some concern, but not nearly so much now in older women as it used to be. If the person has been regularly screened, and all younger women should be regularly screened for cervical cancer, and they have had normal smears up to the age of 65, then it can stop. Many old women have never been screened or have had a previous abnormal smear. In those circumstances, they should be screened yearly till there have been 2 normal smears obtained 1 year apart. So that's basically what we should do if there is to deal with cervical cancer. The problem here is, of course, the older women who have not had any screening at any time. Many may be reluctant to be involved in cervical screening and to have a papillomastoid stain done on a smear at a later year. Abdominal aortic aneurysm. Now, an aneurysm is a bulge in a blood vessel, an artery. And we do know that these can be extremely dangerous. The USPSTF is the United States Preventive Task Force, Preventive Services Task Force, and that usually makes recommendations as to what should be done in terms of prevention. It bases all the evidence on positive and negative findings, and it grades the findings according to A's and B's. We do know that in men who've smoked, they should be screened at least once to determine whether they've got an aneurysm. This is usually an abdominal aortic aneurysm. It could be any place in the aorta, from the arch of the aorta down to the bifurcation at the iliac arteries. But we know that if men have been screened and are found to have an aneurysm and it has been operated on, there is an improvement in mortality, and therefore we should consider it. There is no recommendation from the USPSTF for screening for abdominal aortic aneurysm for non-smoking men, and it advises against screening in women, either those who have smoked or who have not smoked. So basically, men who have smoked should be screened for abdominal aortic aneurysm. If it's present, they should be seen by a vascular surgeon, and he or she will determine whether surgery is then required. Now let's move on to some other areas. Vision and hearing. Visual impairment can have a major impact, negative impact on the quality of life in later years. And we do know that blindness increases with advancing years. The major causes of blindness are cataract, macular degeneration, glaucoma, and diabetes. Cataract is something that will happen in nearly all older individuals. It should be looked for regularly at their standard physical examination, and when the cataract is ripe, that is when it's at an appropriate stage of development, removal of the cataract will often allow that individual to see much, much better. Macular degeneration is a bigger problem. Macular degeneration is deterioration of the retina, and here there is two kinds, wet and dry macular degeneration. The individual who develops macular degeneration usually will end up blind. However, nowadays, for some types of macular degeneration, there are some interventions which are starting to show some benefit. We've also been able to do some benefit with stem cell implants have been used to indicate, to prevent or try and cure macular degeneration. That is in its infancy, but hopefully we'll see a lot more beneficial results in that direction. Glaucoma, which is increasing pressure of the eye chambers, again is important. It should be detected at an early stage. Glaucoma will cause pressure on the optic nerve. If the optic nerve is damaged, you will stop seeing. Therefore, glaucoma should be tested, and that is when the pressure in your eye is tested regularly at your ophthalmologist. If there is glaucoma, medication can be used to prevent that developing, and in some instances, surgery may be of value. In terms of vision, we should always check a person's vision using a Snellen chart at regular yearly or 2-yearly examinations, so that you can document whether there has been a change in vision. If there has been a change in visual acuity, then the person should be referred to an appropriate ophthalmic institution. Hearing, again, is extremely important and a major problem in later years. There are two kinds of hearing impairment. There are those that are due to an accumulation of wax in the ears, and again, this can be dealt with very simply, but it's amazing how frequently you find large chunks of wax occluding the external auditory matters of people who complain of deaf. Hearing can be due to conduction deficits or it can be due to nerve deficits. And what we're going to do in terms of testing it is use the whispered speech test, where an individual is asked to hear somebody whispering behind their ear, whether they can hear that or not. When there is a major hearing deficit, it's important that the individual should have the evaluation of an audiometrist so that they can check out how severe it is. Now, a little bit of bone disease, and this is osteoporosis. Osteoporosis basically affects older women in the age of from perimenopausal time upwards. It also affects older men, usually older men over 75. We have not really paid too much attention to osteoporosis in men until recently. The recommendations are that women over the age of 65 should be screened by dietary history and by bone densitometry every 2 years. Dietary history is important to determine whether they are taking adequate calcium and adequate vitamin D, both of which will help to prevent osteoporosis. If there is a high risk of osteoporosis, and that's in individuals who've got a high family fracture risk, or or individuals had a family has had a fracture before, screening should start earlier than 65, round about 60. When you stop screening, it's now thought that screening should happen if the person, when they have bone densitometry, has no evidence of osteoporosis. So basically, we screen individuals with a standard once at 65 bone density estimation. If they have osteoporosis, then they need to be treated and screened every 2 years until it improves. If they don't have any evidence of osteoporosis, the thought by some specialists who deal with bone disease is that it can be discontinued in that setting. Check dietary calcium intake, check mobility, check serum vitamin D levels in osteoporotic subjects, and again, back to exercise, regular weight-bearing exercises for those at all ages who have got osteoporosis or not. It will be beneficial. Let's talk a bit about hypertension. High blood pressure is what we're going to discuss first. Blood pressure tends to increase in older individuals. That has been known for a long time. The normal range for blood pressure for older adults is higher than in middle-aged. We treat basically if there are consistent levels of blood pressure greater than 150 systolic and 90 diastolic. And what I'm saying, important thing here, is consistent levels. One elevated blood pressure does not mean treatment. This is where the protocol in evaluating blood pressure is important. Many people do not follow the protocol adequately. Blood pressure should be taken with the individual in a resting state after at least 10 minutes rest, and before they are diagnosed as being hypertensive, there should be 3 consecutive readings of raised blood pressure at different time intervals. One raised blood pressure is not appropriate for treatment unless, of course, it is really grossly up, such as 200 over 150. So make sure that you follow the appropriate protocol in evaluating blood pressure, because it frequently occurs that people are put on antihypertensive medication for very dubious reasons. The aim of reducing blood pressure in the elderly is less marked than in younger individuals. We do not want to lower the systolic blood pressure less than 120 millimeters of mercury. If it's less than that, it may be dangerous to many elderly people who will develop postural hypotension, which may be associated with falls and impaired quality of life. So a blood pressure of 120, 130, 140 is fine. We're not trying to get the blood pressure down to 110, 105. That is dangerous. It's important also to remember that the treatment of hypertension in later years can cause increasing side effects. These again increase the older you are. And in many individuals, the side effects of antihypertensive medication when a person is in their 80s is too much to cope with in terms of their quality of life. The important thing to remember is quality of life is extremely relevant in all of these interventions. And if the quality of life is impaired by the intervention, it should be discussed with the older person to decide whether they want to continue with that intervention. Dyslipidemia, cholesterol levels, triglyceride levels, bad fat, good fat. What happens in the elderly? Well, basically, I've got here on this slide the levels that we're trying to aim for serum cholesterol, for low-density lipoprotein, and for high-density lipoprotein. High-density lipoprotein are the good lipoproteins. Low-density lipoprotein are the bad ones. And we're trying to get levels below these levels, but above 40 milligrams per deciliter for high-density lipoproteins. The levels to aim for are appropriate, but these only apply to people who've got a positive cardiac history. If a person has had no cardiac problems, if they don't have myocardial ischemia, if they've not had a heart attack, and their levels are around about normal, we're not going to do anything about it. Indeed, if their levels are elevated and they don't have any cardiac history, it's moot whether, again, we should intervene in those individuals. The other thing to remember is that there are increasing side effects and reducing efficacy of intervention drugs with lipid-lowering agents with age. So again, quality of life has got to be considered in all of this. Dementia. The Task Force on Screening does not recommend that dementia screening should be undertaken in the absence of symptoms. If there are symptoms appropriate for a potential diagnosis of dementia, then by all means screen. But we don't screen for dementia when there is no clinical symptoms at all. It's also important that if we do screen, we use validated instruments, the mini-mental state exam, the clock drawing test, and all of the other ones. These again you'll find in the Try This assessment series from consultgerrn.org. So the important thing is, in terms of dementia, we do not screen unless there are symptoms. The symptoms, of course, will not be mentioned by the older person, they'll be mentioned by the caregivers. Depression, common in older people. Many older people have depression unrecognized. It's associated with increased mortality, increased morbidity, reduced quality of life. Again, we should screen for depression if any of these problems, such as undue sadness, withdrawal from life events, and so on, happens. Again, we have standardized instruments, and you'll find them in the same source as I mentioned earlier. It's important, if you are going to screen for depression, that there is treatment backup available and the old person will use it. In my experience, many older people will not use backup treatment for depression because they think that it is labeling them as a psychiatric patient. And for many old people, that is a no-no. Additional screenings. Thyroid disease is frequent in older people, and by this I mean an underactive thyroid. About 5 to 10% of older women do have underactive thyroids. So it's worthwhile screening for thyroid disease in older people. Here you should check thyroid stimulating hormone or T4 levels. Diabetes you should screen for anytime you see an older person. It increases in frequency in later years, and again higher frequency in many ethnic groups. Those with symptoms should be checked, and those with hyperlipidemia. Let's talk a little bit about medication reconciliation. It's important that the regular visits, the older person is asked to bring all the medications with them, those that they have been prescribed, and those that they've borrowed from neighbours, and those that are over the counter. Because the interactions between all of these may have a major adverse effect on the effect of the medications. Check that the older person knows what the medication is. Check that they can see what colour it is. This is a major issue with people who've got poor eyesight. Check that they can understand the proper dose and also the proper time frame. They should also be aware of some of the side effects, but it's also important that the side effects are mentioned in a reasonably restrained manner, because you will find that many older people will not take medication if the side effects are dwelt with in extremely lurid fashion. And this frequently happens. You've seen these adverts on television for medications, and then it spends the next half of the advert telling the contraindication of what to do if you get any of these things, which frightens most of the old people totally. and frightens me as well when I hear them. So be careful when you are listing side effects. Let them know about side effects, but point out that the side effects are unusual and that you're expecting benefit from the medication. Check over-the-counter compatibility with prescription medications. These may interfere. Other things you've got to remember is person taking calcium, that may prevent the absorption of other medications. So they've got to make sure that calcium and other medications are not taken at the same time. Check alternative medicines for compatibility as well. Many people will take alternative medications, herbal remedies, ethnic type remedies and so on, and these may have major side effects too. So important you check these out. And be also aware of interactions between drug and food. The amount of food an individual takes and the type of food may affect the absorption of medication. So it's important that they are aware when they should take the medication in relation to when they eat. Some medications should be taken on an empty stomach, some should be taken when there's food in the stomach, some should be taken several hours after food. So important to inquire of the pharmacist or the physician or the nurse prescribing it what to do in terms of taking medication in relation to food intake. Here are some lab tests which are found to be non-beneficial by the Public Health Service Preventive Medicine Task Force. Routine lab testing for yearly blood tests for hemoglobin, white blood cell count, no value. There should be an indication for it. Standard blood chemistry, no value unless the person's got symptoms. And a cardiogram, no value unless the person again has symptoms. A routine chest x-ray, again no value unless the person has symptoms. In other words, these tests should only be done if the person has symptoms which suggest these are relatively important. Hormone replacement therapy, that should not be used in terms of older people. We used to use it considerably for osteoporosis to try and replace estrogens at the time of the menopause, because we do know that estrogen lack is one of the causes of osteoporosis. However, we did find that when we used hormone replacement therapy, there was an increased amount of breast cancer, an increased amount of uterine cancer. So we don't use it at all. Now, lung cancer, ovarian cancer, bladder cancer, pancreatic cancer, all severe cancers, we don't screen for them because there is no standard way to do this except in the setting of symptoms. If a person has got symptoms suggestive of any of these types of cancer, we will screen for them. But there's no evidence that screening for them on a routine way, in the absence of any symptoms, is beneficial either health-wise or cost-effective-wise. Finally, it's important to remember that cost should not be an issue in terms of an old person seeking medical advice. Medicare now pays for a yearly wellness visit to the patient's primary care physician at no cost to the patient. The doctor should be happy about this because he gets paid more for the wellness visit than he does for a standard Medicare visit. So it's important that we let our patients know that there's no cost to them in terms of getting a yearly wellness visit from their physician. And that should go in a long way to using preventive strategies beneficially for the older person. You've now completed this module on preventive care. Hopefully you got a reasonable amount of new information from it, or it refreshed the information you already have. It's important that you try and put into practice most of the points that were raised here, and also that you use the negative facts appropriately as well, so that we don't overscreen individuals for screening areas which are not valid. Thank you.